My name is Julia Campion, and I'm the Senior Manager of Trauma-Informed Care at the Riverside Trauma Center and MindWise Innovations. It is my absolute privilege to introduce our next presenter, Dr. Margaret Blaustein. With Christine Kinneberg, Dr. Blaustein is co-developer of the Attachment, Regulation, and Competency Treatment Framework, ARC, and co-author of the text, Treating Complex Trauma in Children and Adolescents, Fostering Resilience Through Attachment, Self-Regulation, and Competence. Dr. Blaustein's work is so influential to the work we do at Riverside, so I am thrilled she is here with us today. Many of us often say, I'm meeting my student or client or person served where they're at. And maybe it becomes one of those things we say so frequently that it loses some of its meaning. But Dr. Blaustein's work in the field of childhood trauma and resilience helps us understand why the idea of meeting someone where they are is so significant across the life course. In ARC, Dr. Blaustein and Kinneberg write, our goal is for children to more than physically survive. We want them to adapt successfully to a world that goes beyond a context of danger and deprivation. By understanding the factors that promote resilience, we are able to target and support those factors. And I think this is what it means to meet someone where they are, understanding and responding to the systemic, external, and internal factors that have led a person to where they are today, their traumas, the chronic stressors of their environments, and also understanding and promoting the factors that support their healthy development and resilience. Thank you so much for being here today, Dr. Blaustein.
Thank you for that lovely introduction. And it's really fabulous to be here today. I'm so thrilled to be a part of this conference and very humbled to follow Dr. Butler Barnes's amazing presentation and to be here. And I want to thank Dr. Berkowitz and Riverside and MindWise for the invitation to be part of this conference today. I want to start my presentation first by acknowledging that the Center for Trauma Training, which is my organization, resides on the ancestral and unceded lands of the Massachusetts and Pawtucket tribal nations. I honor these communities and the elders of these nations, past, present, and future, whose practices and spiritualities are tied to the land. I recognize the enduring relationships between Indigenous communities and the traditional territories that our site occupies, and acknowledge the painful history and enduring legacies of colonization, genocide, and forced removal. I recognize and honor the diverse Indigenous communities still connected to this land in which I live, learn, and raise my family. So hopefully you all are seeing my screen now. I'm going to be talking today about how we can shift the lens for childhood trauma treatment, and you'll get more of what I mean as I go forward, but really to think about our approach to working with, supporting, and collaborating with youth and families who've experienced adversity and stress in childhood, which is far more youth and children, I think, than we would necessarily even wish to acknowledge, that the focus of that work has to be on cultivating resilience. And I would love to reiterate the message that was shared at the very beginning of this conference of how critical self-care and self-reflection is. We're obviously spending this day talking about resilience, but we're also talking about trauma and traumatic stress and its legacies, both in the individual and in the collective. And so it's worth, as we continue to go, to tune into how you're doing and what you need to do for yourself to continue to feel comfortable. So I'm going to ask you to start just by taking a moment to be curious. When you think of the word trauma, what do you think of? What is it that comes to mind? What types of events or experiences? What are the impacts? Right? Just notice for yourself what it is you think of when you think of the word trauma. And often, as a society, when we think of the word trauma, what we think of or what we see, the face that comes into the world is this, right? It's the images of mass casualty events, of acts of terror, right, of September 11th, or of natural disasters, of Hurricane Katrina, for instance, other types of storms and flooding and wildfires, and the impacts they have on collective groups of people, right? In recent years, we've heard many times about the impact of violence, right, such as school shootings, or of the COVID-19 pandemic, which is a big part of what we're talking about today in this conference. But of course, the face of trauma in reality is much broader than that. And it's one that often isn't talked about outside of forums like this among individuals and providers who work with this impact on a daily basis, right? The face of trauma is not necessarily one that makes headlines. So the face of trauma is the hidden face of sexual exploitation. It's the face of poverty and of food insecurity, right? It's the mass incarceration of youth of color in this society and the legacies of structural racism that Dr. Butler Barnes spoke about. And the face of trauma isn't necessarily what you expect to see, because you can't look at a young person and know what they have experienced in their life, what their family has experienced, or what their community has experienced, right? The face of trauma is broad. Now, we don't have, the time to go into all the statistics that I sometimes like to share. But we'll just say that trauma is not rare, as you all know, right? The experience of trauma is the rule and not necessarily the exception for many young people in our society, right? Whether we're thinking about individually experienced acts of violence, right? Or we're thinking about community experienced acts of violence, we know that a huge proportion of youth report experiencing violence in their families, right? And a lot of what is reported underestimates what actually occurs. It's not just within families, it's within communities, it's in school settings, it's in neighborhoods, right? A significant proportion of young people have experienced violence in their lives. But then we go beyond these sort of traditionally viewed acts of commission, right? The things that sort of meet that benchmark. If you work in the psychiatric field, you know that for PTSD, to get that PTSD diagnosis, which we'll talk about in a moment, you have to have a very specific, definable type of trauma exposure, which involves typically acts of commission, things that happen to you as an individual and lead to fear for your life or significant physical impact. But that leaves out a huge number of stressors and adversities that impact young people in this country, right? Things like the fact that 1 in 5 kids in this country lives in a family that is experiencing food insecurity, right? As many as 40% of households with children have housing problems. So these are huge layers of stress and adversity that aren't covered in our classic diagnostic understanding of the impact of stress. And we know that there's disproportionality in these impacts, right? There's structures in place which lead to disproportionate impact of these societal stressors on youth of color. Sit with this number for a moment. Over 2 million youth in this country are arrested every year. Over 2 million youth are arrested. And this is 1 in 5 of all arrests. So 1 in 5 of every arrest that happens in this country is of someone under the age of 18. And beyond the relevance to trauma, because the arrest and incarceration is itself a traumatic experience, we know that youth who've been arrested are disproportionately youth who've experienced multiple layers of childhood adversity, right? In one large-scale study, more than 50% had experienced 6 or more layers of adversity by the time of detention, which in this particular sample was on average at 14 years old. And as was talked about in the previous presentation, this mass incarceration is an example of systemic experiences of trauma. that occurred in our society, right? The disproportionate arrest, African American youth, for instance, are 129% more likely to be arrested than white youth, 19% more likely to be committed to a juvenile facility. And we know that this disproportionality has actually gone up over time, right? So these disparities across racial groups have gone up even as the numbers of total arrests have gone down. And increasingly, there is a recognition that when we talk about adversity in childhood, we need to pay attention not just to the individual experiences of adversity, but the social and contextual environments that overlay and often facilitate those individual experiences, right? Most of us are familiar at this point with the Adverse Childhood Experiences Study, which was groundbreaking in its work looking at the ways that experiences of childhood have a toxic impact on outcomes in adulthood, right? But we've expanded our understanding in the many years since those studies were first published back in the late 90s to understand the broader array of potentially traumatic or adverse experiences of childhood and the ways that community environments both facilitate and layer onto those experiences. So, anytime I sit and start to talk about potentially traumatic experiences of childhood, it gets a little bit overwhelming, right? Because the number of potential exposures is so large, right? You can't really make a list, right? I start to make these lists of what are potential traumatic exposures of childhood, what are examples of things that young people experience in our society, and there's so many of them. We have this one little word, trauma, as if it's all the same, right? As if when we talk about the impact of stress, that every single stressor that is experienced is exactly the same, and we should expect a singular outcome and a singular impact. And of course, that can't be true, right? There are so many examples here of chronic, potentially traumatic experiences that can happen in development, the overlay of acute trauma that is often exacerbating. And so earlier, when I showed those pictures, right, of what makes it into the media and what sort of doesn't as often, keep in mind that those acute experiences, right, things like September 11th or Hurricane Katrina, these natural disasters, COVID, the experience isn't felt the same for every demographic group, right? So Hurricane Katrina, just as an example, was a natural disaster whose impacts were far exacerbated because it was a natural disaster overlaid on a community that was already experiencing structural and systemic inequities, right? And was further exacerbated by the failure of service provision that happened as a result, right? So things are not singular on their surface. Dr. Butler-Barnes spoke about the ways that the COVID pandemic coincided with the pandemic of racism and has continued to, and those things intertwine in their impact and in their influence on people's experience. Trauma is complex. There are so many dimensions of traumatic experience, and trauma is complex in the experience itself, but it's also complex in the ways that it intertwines with the individual who experiences it. We are not all the same. We are not all the same people. We all have different aspects to who we are. We have different layers of social support. We have different levels of societal issues which impact us, right? Some of us have resources and some of us don't. Some of us have a lot of social support. Some of us have less of that. Some of us have additional vulnerabilities, right? Some of us have fewer of those. And there is this layering both of adverse experience, right? The more layers, the higher the risk, but there's also the buffering impact of layers of resource. The more layers of resource we have, the more buffered we are from those experiences. So in understanding the influence of any traumatic experience, we really need to understand all of these multiple layers. At the end of the day, we need to understand the individual and the family and the context and the community, right? We know that the impact of trauma is potentially pervasive. And I always want to say potentially because there's not ever a one-to-one correlation, right? There's over 200 people in this conversation right now at this conference, and a fairly significant percentage of us have experienced adversity in our lives in various ways and differentially, right? With different layers of impact and different layers of experience. And many of us have, I would hope, thrived despite those experiences in our lives. But that's thinking about the ways that our resources have influenced us, right? And it's never to say that we haven't been impacted. So we know the impact of trauma is potentially pervasive, right? The original ACEs study looked at all sorts of adult outcomes. It was originally a study that was interested in health outcomes, right? That was the goal of the study. They were looking at various health outcomes. It became over time a study of adversity in childhood, but it was really a health outcomes study. And what was found pretty clearly was that childhood trauma is toxic to development, right? There's very few outcomes that are looked at in which the risk is not greater with the experience of adversity in childhood. And this comes out in our language about kids, right? So that was a study in adulthood and everything's nice and neat in categories, but we talk about kids in a way that describes their pathology, right? So at one point I was doing a talk and I was talking about developmental trauma, and I went back and I pulled like the most recent 15 referrals I had gotten. Just out of curiosity, I wanted to take a look at what were kids coming in for, what were the reasons for referral, how were people describing these young people, and this is how kids are described coming in, right? This is 15 kids, all of whom have experienced significant trauma and adversity in their life. But what they're described at is impulsive and distractible and explosive and pleasing and shy and lying and odd, right? Academic trouble, sleep problems, stealing, hoarding, right? All of these behaviors, this is how kids are seen. And these were the descriptions, not necessarily of primary caregivers, but sometimes, but they were also the descriptions of the service systems that were referring youth in. Now, if we use this kind of behavioral lens, the psychiatric lens, we end up with kids who have a laundry list of diagnoses, right? And so if you stop and you think about the young people who are coming into your system, chances are many of them carry a range of psychiatric labels, right? They're described with generalized anxiety disorder, or oppositional defiant disorder, or disruptive mood dysregulation disorder. I always get that one wrong. Depressive disorder, substance abuse, right? We have a range of diagnoses that we use to describe kids that are largely describing the most sort of obvious presenting feature of what they're showing, and that are disconnected from their experiences, right? None of these, if I go back a slide, none of these link back to the experience that led to the symptomatic or behavioral demonstration of what the child is experiencing. And if we guide our intervention purely by diagnosis, typically what we're trying to do is reduce pathology, right? That's the goal of treatment guided by diagnosis. There's an emphasis on pathology reduction. If you look at the sort of evidence-based literature for any diagnosis, typically there's a look at here's what the diagnosis or the level of symptomatology, the level of, they have a T-score of this when they enter the treatment, and 16 weeks later, is there a reduction in that T-score? Right? Is there a reduction in the clinical significance of the presenting pathology? And if there is, then the treatment has an evidence base, right? We could try, for instance, to take a child who's being oppositional and say, we want to treat the oppositionality. This is a child who's being oppositional and refusing to go to school, or being really challenging with adults. And if our treatment goal is to get them to comply more, then we're going to use all sorts of limit setting and behavioral intervention and consequences for the child or the caregiver. And we might stop the behavior, But have we done anything to address what's leading to the distress or the behavior in the first place? Right? Probably not. As long as we think of our intervention being about pathology reduction, we're missing our understanding of the individual who we're sitting with, right? The fallout of these pathology-focused interventions is that we're emphasizing skill building without understanding individual adaptation, right? And what that leads to is a lot of shaming and blaming of youth and families, right? If we build skills, what we're saying to a child is, you're doing it wrong. You should be doing it like this. We're saying to parents, you're doing this wrong. You should be parenting like this, right? And it's not astonishing that there's a lot of disengagement and disconnection from services that happens because people don't feel seen or attuned to. Resmaa Menakem has this quote that I love, and it really speaks to the cultural deficit model that Dr. Butler Barnes was referencing before, and that is so endemic to our intervention field, right? Where we disconnect someone's experiences from their current adaptations. So the quote is, trauma in a person decontextualized over time looks like personality. Trauma in a family decontextualized over time looks like family traits, and trauma in a people decontextualized over time looks like culture. If we disconnect someone's history and their experiences, right, on the individual and community levels from their presentation, it's really easy to pathologize it. Right. And then it's really easy for the emphasis of any intervention or service provision or support given to be about reducing pathology, and along with it, a healthy dose of shame and blame for the pathology to exist in the first place. Right. I'm going to show you like half a slide here, and I'll go to the other half in a moment. But as part of their work looking at adverse childhood experiences, the CDC showed this projected path of adversity in childhood to the potential outcomes, right? So you have adverse childhood experiences leading to impairment, social impairment, emotional impairment, cognitive impairment, which then leads to health risk behaviors, which was the point of interest of the CDC initially, which in turn leads to disease and disability, social problems, and eventually early death, mortality, and morbidity associated with adversity in childhood. What this doesn't do is incorporate the context that facilitates that adversity in the first place, right? Or the context surrounding those experiences. And so the RISE Center expanded this pyramid in a way that acknowledges that complex trauma and adversity is facilitated by the social conditions and context in which it's embedded, right? We have to look at the impact, for instance, of historical trauma and the generational embodiment of the legacies of those historical traumas and the ways those are continued by current conditions, which then leads to this increasing over time risk and experience of complex trauma and adversity. And that can happen in all sorts of ways through all sorts of pathways. And instead of then looking at impairment, we're looking at the ways these experiences place a load on the individual's development, leading to coping strategies, right? And these coping strategies in turn often lead to stigmatization and criminalization, right? And we end up in that same outcome place of morbidity, mortality. Right. I always say it's ironic to me because you can look at young people, behavior makes sense. You can look at what people are doing and the ways that they're navigating their world, and people do what they do with purpose, right? But so many of the coping strategies and adaptations that young people develop are considered toxic to the people around them. And so kids get referred to me because of their coping strategies and their adaptations. Right. And then our intervention system is supposed to tell them that those adaptations are wrong. Right. So we send kids in for services because of what they're trying to do to survive their world. So what are kids used to being asked? Right. What are the questions that kids who've experienced trauma are used to, or that families who've experienced trauma are used to? It's what's wrong with you? right? What's wrong with you? What's wrong with your kid? Why is he having such a hard time, right? What's up with these behaviors? Why can't he just listen better? Why can't he just behave in class? Why can't she just talk more and be more outgoing and be more friendly, right? And isn't all this stuff just an excuse? How can this stuff that happened so long ago still continue to impact them? So we want to ask different questions. We need to shift the lens, right? And think this range of questions, and I think they're all important. So I'm going to read through them. Okay. What are some of the factors that influence this individual child's approach to the world? Right? They could be cultural norms and influences, familial norms and influences, individual factors like neurotype, right? And personality and temperament, sensory needs, all of these are going to influence how a child begins to engage with the world around them. And then we layer on what has this child or the child's family or the child's community experienced in their own lifetime and across generations, and how might these individual and collective experiences have affected them, right? Quite simply, we can say, what do I think this child's lens is for the world, for himself or herself or themselves? What is the lens for other people and relationships? Given all of that, how has this child learned to manage their own experience, right? What have they learned to do to regulate their bodies? What have they learned is acceptable to do in different contexts? And what gets them in trouble in different contexts? How have they learned to get their needs met? How have they learned to navigate their worlds? And why do the behaviors make sense? Right? Trauma and adversity, like all experience, shapes the course of development. Our development is not like stamped from the beginning, right? We do not come into this world with brains that are 100% formed. Our brains are deeply influenced by the experiences that we have, right? On a neurological level, we grow in response to the experience that shapes us, right? And our brain is literally shaped by that experience. We learn to respond to the world that we live in, okay? Trauma and adversity is a pretty phenomenal shaper of learning, of brain development, okay? It is deeply impactful to how our brains develop. Having said that, I always like to oversimplify things a little bit, right? It's very complex. Trauma's impact on development is complex and multifaceted in so many ways, but if you want to break it down really simple, there's two major impacts that trauma has on development. Number one, kids get really good at all the things that help them survive their world, right? All of those domains of skill and competency and adaptation that help them navigate moments of danger, achieve safety, and get their physical, emotional, and relational needs met. Okay, so if I learn that I have to manage people around me to get my needs met, then that's what I'm going to do. And then someone else is going to call it manipulation, right? If I learn that the only way for me to have any control in this world is to like keep my boundary tight and not do what you're pulling me to do, then I'm going to do that. Someone else is going to call that oppositionality. All right. Kids get really good at all of those adaptations they need to help them survive their world. On the other hand, maybe not so much energy going into everything else, right? Because our brain prioritizes what's essential. So kids prioritize survival skills and strategies that help them navigate their world, and their brains de-emphasize other aspects of experience, which may be less immediately relevant, except for in those moments when the brain has the resource to put energy there. Okay. And where does our treatment often focus? If we think about those two areas, where does our treatment focus? It's typically on the first one, right? On that prioritization of domains of skill and adaptation, which are helping the child survive the world, but we don't call it that. Okay, and we don't look at it that way. Treatment often focuses on behaviors. Those behaviors, which also happen to be adaptation, strengths, and skills that kids often have. And when we prioritize behavior in our treatment, then we engage in a wide range of interventions which are designed to reduce those behaviors, those adaptation strategies, which are viewed as impacting the child's functioning and often viewed as impacting other people's functioning across environments. Often the kids who get referred into services young are the ones who are causing problems for other people as a result of their responses to their experience. Often the kids that are in some ways causing the most problems for themselves, that have more of that internally directed adaptation, right? The things that go inward, we often don't see those kids until a little bit later on. Okay, so we prioritize behavior. And then what does our treatment approach communicate to youth and families, right? When our prioritization is of pathology, what we're saying to kids is this is who you are. You are the manipulative kid. You're the impulsive kid, right? We see kids as their most prominent behavior. We do this on our intakes. We sit down with kids, we learn about them, and we say to, families, what are all the problems right now? We say this to referral resources. What are the problems right now? And I understand that this is sort of how our service system is organized, but this should never be how we enter into relationship with youth and families, right? Because we are communicating both implicitly and explicitly that kids are the most prominent of families, not just the kids, right? The caregiving system, the entire family is the most prominent, challenging manifestation of their experience. So we need a different lens. We need to shift the lens for how we view and how we approach treatment. Okay, so if we don't want to focus on pathology, and I'm not saying we don't want to reduce the challenges for young people, right? Of course, we want to reduce those challenges that are interfering with their capacity to navigate their world in a way that is important to them and that matters to them. But that's an outcome, right? That's an outcome that happens when we engage with the whole child. We're shifting our focus towards really supporting positive and healthy outcomes, right? If we understand trauma as having a pervasive impact on youth development, if we understand that the experience of stress and adversity in childhood is deeply impactful to the healthy, joyful experience of youth and families, then shouldn't our goal for services be the healthy, joyful experience of youth and families, right? Like that's what we're going for. That's our goal of treatment. So there's a lot of words that I happen to really love that are part of how I think about this work. And there's a bunch of them that I actually really love. I'm going to focus in on one of them in this talk, and that word is possibility. Okay, the possible. I really love this word. And possibility, when we think about possibility, I think there's this sort of fallacy in how we think about possibility as almost fantasy. Well, I don't know, that's possible, right? It's possible that could happen. It's not likely, but it's possible. But that's not what possibility really is. Okay, possible is actually something that already exists. The seeds for the possible exist. Possible is not impossible. Possible is achievable. It's the potential. Possible is something that we are able to be or become. It's something which is likely, right? And if I illustrate that with a picture, my favorite sort of symbolic picture, if we illustrate that with a picture, start with taking a look at the acorns over here on the left, right? This is a really common sight. For any of you that are watching this from anywhere in New England, in the fall, there are tons of these acorns all over the ground. We don't even notice them. We step on them, we crunch them, the squirrels take them away, right? They're these almost annoyances as we're clearing our yards of leaves or whatever's happening, right? So there's these acorns on the left, but then there's these beautiful oak trees on the right. And the only difference between these acorns on the left and these beautiful, majestic oak trees on the right is the possible, right? It's possibility. And for the acorn to grow into the oak tree, now I will say acorns are super stubborn. right? So like this middle picture here is an acorn that's planted itself in pretty terrible conditions. It doesn't look terrible, but I know where I took this picture, and it's not great conditions for an acorn, but boy, you try pulling this thing out, it's not going to want to come out. It looks like a teeny little weed, but once an acorn plants itself, it takes a lot of work to yank it out of the ground. Acorns want to become oak trees, right? But it's easy to get in the way of it, right? Not enough sunlight, not enough rich environment, not enough resources, right? The acorn's got to work a lot harder to become an oak tree. But let's say you help it out. Let's say you create a world that is resource rich, right? That nurtures the potential the acorn have, and the acorn turns into the oak tree. You didn't create the oak tree, right? Like if I do something to plant an acorn and 30 years later it becomes an oak tree, that wasn't any magic that I did. The acorn was always the oak tree, right? But I created a world that made it less hard for it to get there. Okay. Seeing possibility, right? What's the role of the possible in trauma treatment? I would argue that that's what trauma treatment should be. It shouldn't focus on the broken. It should focus on the possible. Okay, so that's where we're going to go. The next part of our talk is really thinking about how we nurture the possible, right? How we create services that nurture and engage the possible. Take a moment and think about what helped you start to envision or engage or enact your own future, your own possible. And those three words are important: to envision, to start to imagine possibilities, to engage it, right? To step in and lean into your possible, to enact it, to try it out, to act on your world and take power, right? It starts early in our lives. It starts with trying things on. These are my own kids, so I have permission at the moment to share them. But this is what kids do. Kids play roles, right? When you are little, you can be doctor, you can be Wonder Woman, you can be a little boy in a tutu pushing a lawnmower, right? Because anything is possible when you're 3 and 4 years old. And many of us started to play out these different roles. This is how it starts. We see things in the world around us, we try them on, we start to copy what we actually see in reality. So we go from the fantasy to really trying things out, to building and constructing and tending to animals and seeing our heroes on sports teams and then imagining ourselves in those places, right? To doing and connecting with others in practice. And if you look at what you are doing right now and you look back over your life, you can probably see the threads that led you to where you are now. Okay, now for myself, I would never, if you had asked me when I was 12, 15 years old, if I was going to be a psychologist when I was an adult, I would have thought you were absolutely bonkers, right? That was never what I would have predicted that I was going to do. But when I look back now, I can absolutely see the threads that led me to this place, right? It makes absolute sense to me that this is where I ended up, even if it wasn't necessarily what I envisioned as a 10-year-old, right? Because the threads that allowed me to start engaging in the aspects of who I became were laid down young. Right now, I don't know where my kids are going to end up, but my daughter's always loved animals and she says she wants to be a veterinarian, and my son loves to build things and he says he wants to be an engineer. I don't know. They're 11 years old now. I have no idea if that's going to be what happens in the future. Wherever they end up, I bet we will look back and be able to see the threads that led to where they are now. Okay. Because they're envisioning, engaging, and enacting in so many moments. Right? I love this quote. This is a Gloria Steinem quote. Without leaps of imagination or dreaming, we lose the excitement of possibilities, because dreaming is just a form of planning. Right? When we dream about what might be and we start to picture ourselves in it, we start to lay down the foundations for what we become. And childhood is like the optimal time for this, right? When we can imagine all sorts of possibilities, except right? What does trauma do to dreams? What does stress do to dreams? I'm going to share a brief clip, and it's old. It's from a 2020 episode that aired many years ago, and I'm going to share just about 30 seconds of this clip. And in this episode, they followed a group of children, 3 different families over the course of a year from a very poor, high crime neighborhood, and just sort of followed their stories. And interspersed in following in-depth stories, they sat down with these young people and asked them questions. Okay. And this clip, there's a lot that gets shown in this particular documentary, but boy, I find this like 30 seconds one of the most impactful moments of this documentary. It starts just after this little boy, actually.
And what about Josh, who lives in a frightening neighborhood of drug dealers and says he can't see a way to get his single mom out of Camden?
I don't really hope for a lot of stuff like I used to do.
But if you had a dream gift?
My dream gift would.
So she's asking him, I just want to give the context. The holidays are coming up. If you could have anything in the world, okay, if you could have any gift in the world, what would you want?
I like to have my way to I don't know.
So it's this small moment, but it's so illustrative of the impact of trauma to take away possibility, right? This is a kid who's resilient and resourced in so many ways, and we get very brief glimpses of him in this documentary. He's a kid who's a caretaker for his mother, who is ill, and is a really well-spoken young man who you can see this relationship he has with his mom, but there is a burden that he's holding in so many ways. And I'm not going to go into his whole story. This moment of saying, what do you dream? And him not being able to envision what he dreams, right, is just compelling, because without dreams, what do we have? Hope is a passion for the possible, right? How do we, in our work, focus not just on stopping the bad, but envisioning the possible, right? In cultivating and supporting kids and families to be empowered to engage with their worlds in agentic ways, right? That see in themselves health and strength and resource, and that are truly strength-based, right? And not pathology-based. Hope is a passion for the possible. There was a kid I remember that I worked with, a teenager, and she had been resistant for years, right? That's the pathologizing term, resistant for years to coming into treatment, in part because services do not work hard to engage kids and families in a way that they feel welcomed and invited into service systems. But for her, for years, people had wanted her to go to therapy. She hadn't wanted to go to therapy. And suddenly at 16, she decided she did. And she came in, and part of our conversation when we first met was really understanding what it was she was hoping for, what she wanted. And what she said was this: I don't want to be 60 and think of all the things I could have done and not have accomplished them. I don't want to get to that point in my life where I'm focused on all the things I didn't do, right? As opposed to what I want for myself. And so the challenge becomes, how do we get from point A to point B, right? How do we create service systems that engage youth and engage families and engage ourselves as service providers in envisioning and supporting the work that moves the acorn into the oak tree, right? Acknowledging that the acorn is always the oak tree, always has that possibility. Ann Maston, I assume for all of you who are here at a conference on resilience that you know this, is one of the pioneers in the field of resilience. She's done brilliant work looking at the ways that stress impacted individuals and communities can harness and build resilient outcomes. And she talks about these sort of 3 models for engaging positive change. And all of these are critical when we think about doing this work, right? So how can we support resilience? Well, we can do a risk-focused model. And in a risk-focused model, we reduce those things that lead to negative outcome, right? We reduce structural inequities in our society. We reduce the risks associated with disparate access to healthcare. We reduce the risks associated with exposure to violence for young people. Less risk means that we have more positive outcomes. It's critical stuff. Second model for engaging positive change is asset focus. And this says we need to increase access to resources for youth and families. And when we increase resources, it goes a long way towards buffering risks, right? Sometimes we can't remove all risk from society, but we can buffer those risks, right? And so in the first talk, we heard about the ways that relationships and social support buffered the impacts of the pandemic and on exposure to racism among youth. And I may be quoting the studies wrong, but the resources buffered the risk. The more resources we have, the more access to resources we have, the more we can buffer the impact of some of the risks on youth, therefore leading to positive change. And then the third model, and this is the one that I'm going to talk about in the small little bit of time we have left, is adaptive system focus. This is the one that focuses not just on what surrounds the individual, but what is inside the individual. And that's the adaptive system focus. This is where we engage and nurture these powerful engines of resilience. Yeah, I love the sound of that, right? How can I be a provider who engages with, who sees, and who works to support these powerful engines of resilience that are already within the child, that are already within the family, right? If you are an individual provider, this is often what you have access to, right? We can work with systems. I do a lot of work with systems. This is actually a big part of my job, is to work to support organizations towards whole systems, trauma-informed practice. But as an individual practitioner, where I also have the potential to have agency and impact is with these powerful engines of resilience within the individual, within the family. What are these powerful engines of resilience? And so if we think about the individual child, this is broad generalization, by the way, here. So I'm not even looking at the very specific predictors of resilience, subgroups of children, or an experience. Broadly across studies, there are these reflective capacities that are associated with resourced outcome over time, right? Having a sense of identity, reflection on self, autonomy, competence, self-efficacy, having embedded relationships, being able to connect and have a sense of connections and relationships, right? Being able to engage with our world in active ways. Those are all predictors of resilience over time. And these are these reflective capacities that are really critical for engaging with our world in active, goal-oriented ways. We know that these are all impacted by trauma and stress, right? So these things that are critical predictors, these powerful engines, right, of positive outcome are also things that are powerfully impacted by stress and adversity. And it makes total sense that these are impacted by stress and adversity for all sorts of reasons, not the least of which is that our brain has to prioritize survival in the presence of danger, right? And so if we are experiencing felt danger in our world and our physiological arousal is up, our brain is going to go into self-protection mode. And when that happens, our reflective capacities start to shut down because they're not essential to survival in that moment of danger, right? And so our brain has to prioritize survival, right? So a lot of kids who've experienced early stress show these impacts on self-knowledge and competency, on social connection and feeling safe in relationships and able to navigate those relationships and having a sense of agency in the world and being able to solve problems, right? So this has to become part of the focus of our intervention. Now, I will say, I'm going to talk about these 3 areas, just very briefly, that we're trying to support: reflection on self, reflection on others, reflection on the world, all of which are sort of core to helping us start to envision our own possibilities. We can only do this in a child who feels safe, with a child who feels safe. So reflective capacities have to be something that is addressed in collaboration with also supporting both the child's physiological, their body safety, their emotional safety, but also their environmental safety, right? Because we can do all the supportive stuff in the world, but the brain has to be able to access it. So I just want to acknowledge that as I'm talking about building reflective capacities. And we're going to very briefly speak about each of these. Okay, how we reflect, how we cultivate curiosity. I'll say possibility is one of my favorite words. Curiosity is another one. Curiosity, I think, is just at the heart of our work and needs to be at the heart of our work. Okay, so let's start with reflection on others and relationships. I always want to challenge people to think about your own way of being in the world as we think about how we engage and how we work with clients, with youth, with families, right? Consider your own ways of connecting, because we learn from ourselves, right? If we're reflective and curious and pay attention to our own strengths and challenges and our areas of resource and our areas of need, right? Think about how you connect, what you're comfortable with and what you're uncomfortable with. Do you avoid connections that you're uncomfortable with? Are you able to? Do you have the agency and autonomy that lets you disconnect from things that are hard? Not all kids do, right? How has your history of relationships influenced your own ability to connect? If you think about what you've sustained over time, what influences that? Right? What influences who you're able to sustain connection with? Is it about access? Is it about your skill set? Is it about your comfort level? Is it about what you want in your life? Is it all of those or none of those? Right? When do you feel most able to connect? When do you feel least able to connect? And how comfortable are you reaching out and asking for support when you need it? And why might that be? Think about how many kids are told that their strategy when they're anxious is they should go find an adult and talk to them, right? And we're often saying that to kids who feel the least safe in relationship and the least able to access supports, and who are often seen as not even necessarily worthy of those supports, right? Because the kid is the one creating the problem. So think about all the things that impact our ability to connect in any given moment. What are some of our goals? And I could spend a day on each of these, so I'm going to quickly overview these three areas. If we're working with kids and we want to support connection, right, and you're working individually, you can't just build skill. You have to understand this child's relational and social worlds, right? What has this child's history been of connections? Who have they had in their lives? How have those people influenced them? Are there individuals available to them? And if not, where is that community, right? How can we support a connected community? Where are there opportunities for this child to connect to others? Because a lot of kids maybe have fewer connections available to them, right? How can we help kids become curious about the ways they are in relationship across contexts and across settings? Because it's often really variable for kids, the ways they are able to be in comfortable environments and the ways they need to connect. For instance, if they're a child whose culture is different from the environment they're embedded in, often where they need to mask some aspect of who they are in order to be seen as connecting or communicating appropriately. Right? We can support connection structurally. If you work and play with kids, you can support it in play through, in structurally, we can look at being a frequent presence, mirroring, right? Looking at natural opportunities. Where is the child embedded in community? And are there barriers to being embedded in community for this child or for this family? Can we be curious about and notice and respect child relational boundaries, right? We push kids to talk all the time and to be in connection all the time in school and in service provision and in other settings, when kids are putting up boundaries and saying, that's not comfortable for me. Right? So how do we honor what kids are telling us with their expression? I'm going to move quickly through these because I'm conscious of time. I will send these slides along so you'll have access to these. Just want
I
to name
do
that.
want to just jump in, Dr. Blaustein. We do have a couple questions in the audience. I'm wondering if we might be able to get to one of them before you move on.
Sure. Let me finish the last few slides and
Okay.
then we'll do the questions if
Great.
that's okay.
Yes, thank you.
Sure. Okay. So the second area that we want to really support is reflection on self and identity. And again, I'll move quickly through these so that we can leave a minute or two for questions. And I'll skip over that and think about how we support youth in their sense of who they are, right? Their sense of positive self, what they feel good about, what they feel pride in, how important it is not just to look at areas of self that are from a deficit model, right? What are you not good at? But what do you feel good about? What is your unique self, right? What are your areas of interest and self-expression? All the different ways that you engage in different roles in your life and what you're envisioning. So being curious about future self, right? And this can be as simple as really paying attention to noticing patterns in kids, right? Like I've noticed that you really like such and such. I've noticed that you don't like when I do this. Is that true? Okay, that's really important for me to know about you. How can we invite youth opinions and create opportunities for youth to be in positions of empowerment, to lead conversations and to lead initiatives or to have their voice at the table, right? And to express their preferences for things like clothing and hairstyle and food. And this is something that's being erased, right? We talk about some of the political environment where kids' hairstyle, for instance, is something that's not allowed, so that kids have to hide the natural expressions of self, right, that are culturally or familially influenced. And then finally, reflection on choice and possibility, creating opportunities for empowerment for youth, right? Knowing that they have impact on the world. There are very few people who have as little choice and control as kids. And then you can add on to that in layers, the added layering of disempowerment that young people often have, right? So where are all the opportunities, depending on how you work, in which we can invite choices from kids? You can't, we always say to kids, make good choices. Kids can't make choices if they don't ever feel like they have a choice, right? So thinking about all of the opportunities that we have to support control and empowerment in young people. All right, I'm gonna hold on my last couple of slides in favor of responding to a couple questions. So why don't we shift to that?
Great. Thank you so much. I know everybody is super engaged in your talk, so I really appreciate it. So one question that came up, in working to engage our kids and their communities, their systems, how do we help them see possibilities if their daily systems, family, school, etc., disagree or prune those possibilities away? For example, caregivers who may have rigid behavior focus and actively oppose those models.
Yeah, it's really hard. And it's like too big a question to answer with something simple, right? I mean, I think this is a process over time, right? Because I can't hand a child a possibility. I can be curious about a child's interests. I can be curious about a child's opinions. Part of possibility comes from sort of engaging in the potential of myself in the now, right? And so where are the opportunities for kids to engage in the potential of themselves in the now, right? And so I think this is in some ways where all of that reflection on self comes in. And a big part of reflection on self is being able to enact, right? So being able to do things and see things, for us to see kids as they are. I think that we don't have a huge amount of time to go into this, but part of this is really cultivating attunement in as many adults surrounding the child as we can. So seeing when a child does something to say, wow, it looks like you felt really frustrated with that. I'm so impressed that you found a way to show me that with your behavior. You're really powerful in communicating what you're feeling right now, right? So there's different ways that we can engage with what is that cultivate some of that ground for future. And then ideally also cultivating and working with the caregiving system as well.
Yes, thank you so much. I think the power of attunement there, it's such a critical piece.
Yeah.
One other question, and I do want to be mindful of time, so if folks have to head off, certainly, but we have one other question I want to just get to, which is part of the pathology symptom focus that you were discussing at the beginning is really part of that medical model and the need to pick an approved diagnosis for reimbursement, right? You talk so much about the systems and working with our systems. So do we know whether, and by we, I think the person is asking of you, do you know whether the developmental trauma disorder will be back on the table for consideration in the DSM and the ICD? Do you have any secret dish for us on that?
I wish I did. I don't. I think that, the ICD has gone further than the DSM in acknowledging complex trauma as a diagnostic frame worth considering, right? And PTSD in the DSM continues to acknowledge increasingly complex trauma experiences, but not separate out the experience of developmental trauma as having a more defined diagnostic presentation. I think this fight has been fought for a long time now. I'm not holding my breath.
Well, thank you so much, Dr. Blaustein.